This webinar will be recorded. This is our second webinar together with our EEG expert Olga, PhD, who is running her own clinic in Finland. And the topic of today's webinar is brain mapping and ADHD subtypes. We will explain why it is important to make EEG assessment and apply brain mapping techniques to your customers, clients, patients, whatever you call them, and what kind of ADHD subtypes we have, and why it's important to make the EEG assessment and figure out what kind of subtype is your client, and apply different neurorehabilitation techniques like neurofeedback and others. Olga will start now the presentation. If you have any questions, please feel free to type them in chat. If after the presentation you would like to start the discussion, we will allow you to unmute your microphone and ask questions in person. So please, Olga, go ahead with your presentation. Thank you. But we still have a few people attending, in the waiting room. So maybe we can give them another couple of seconds. I think they're all in. So let's start. Go ahead. I mute.
Thank you, Alex. Thank you for introducing me to our attendees today, and thank you everyone who come today and spend your time for this presentation. So as Alex already mentioned, I have a background in neurobiology, neurophysiology, and in psychology. And also working with quantitative EEG analysis, with ERP analysis, and with neurofeedback, different kind, with neuromodulation. And this webinar is more or less practical. Of course, I'm going to give some general information and just some idea how we can use information that we obtain from the EEG for real practice. So let me then begin. And today, Alex asked me to talk a little bit about ADHD subtypes and how we can define them with EEG techniques. I will tell just a few words about ADHD that probably you all know, but still it's about 8%. In different countries, this percent is different little, but still about 8% of population have this disorder. And of course, it's not the biggest problem, like, for example, anxiety or depression or chronic pain, but still it's affects a lot of people. And in children and in teenager and even in adults, we can find people with ADHD. And if we look in general in epidemiology of this problem, so in kids, ADHD diagnosed after age 3, but normally it's before kids go to the school, so from age 6. So that's why probably we have so many percentage of the diagnosed people from 12 to 17 years old. And besides ADHD, children and teenagers, they also have learning disability, depression, anxiety disorders, Asperger's, and even stroke. So different kind of problems, and sometimes they coexist. As you also know, ADHD is a lifelong problem. So of course it starts in childhood, and we talk about developmental disorder. So unfortunately, even the people grow up, some symptoms may be less pronounced, but still in adults, we can identify ADHD in 50 to 65% of cases if these people had ADHD in childhood. And what is very important, in my opinion, is to understand that ADHD is not, we are not so lucky to have clear ADHD all the time. So it's very often coexist with other problems. For example, in children, we often find ADHD together with some learning disabilities, with depression, a lot with anxiety, or some conduct disorders. And also, if we talk about adults, the same problem, adults with ADHD often suffer with bipolar disorder, with anxiety, with mood disorders of different kind. They could have specific phobias, and besides this, of course, alcohol abuse and so on. Why I'm telling this, it's because in the real practice, you may face with the situation when you have a client, they come to visit you and they already have a diagnosis of ADHD, but they mostly suffer from anxiety or PTSD or something else. And it's always a challenge to understand what is the biggest problem for this client. And also diagnostic is often done with questionnaires. And in my opinion, sometimes is not well distinguished between ADHD and some other condition. Okay, so also ADHD is not just one diagnosis. We have different subtypes of ADHD. And if we talk about DSM-5, we can identify ADHD inattentive type, ADHD impulsive type, and ADHD combined. Combined type we find most often. Sometimes quite rare, we can find pure ADHD impulsive type, and ADHD inattentive type is also quite often we can find. And in children and in adults, more or less the same distribution of these types. Also, as I already mentioned, that this different type of ADHD coexist with other problem, like for example, combined type can also have anxiety and depression, or they could have some aggressive behavior. Hyperactive type especially could have problem in attention and in some social behavior and so on. So all of this I'm showing you just to understand that it's actually quite complex problem. It's not just something very pure diagnosis that we can identify clearly by discussing with some client. And what is the difference between this different type, this three type of ADHD? So inattentive type especially suffer from poor concentration, easily distracted, poor organization skills. They can be daydreaming people, hyperactive, impulsive, they are restless. You immediately will realize what type of person it is. They can't sit still. They have excessive talking problem, difficulties to stay on task. They need to move all the time. And combined type logically has a mixture of these two symptoms. what I was going to also mention, that often in ADHD, we talk about deficiency in the frontal cortical areas. And at the same time, it's well known that we have some frontal lobe syndrome. Of course, this is mostly coming in diagnostic when we talk about some stroke or traumatic brain injury, but still some frontal lobe deficiency, like low motivation, poor attention span, difficulty control emotions, or easily distracted, impulsive, risky behavior, communication, memory problem, and so on, and affective symptoms. All of them fall into the problem with frontal lobe. And also we identify different parts of the frontal areas, like the dorsolateral prefrontal cortex or ventrolateral prefrontal cortex, orbital frontal cortex, also singular cortex. All these areas found to be involved in pathophysiology of ADHD. Sorry, there's some noise and any questions?
Нет, свой я взяла.
That's fine. That's fine. I fixed it. So there was a microphone of one of the students. So go ahead.
Thank you. Right. Okay, so I'm just telling you that we have different areas that can be involved in pathophysiology of particular type of ADHD. And what is found from the neurobiological studies? It was found that ADHD people generally, they have decreased volume in prefrontal areas, in anterior cingulate, in cerebellum, in basal ganglia, and also they have problem with connectivity between the areas and between different structures, like decreased connectivity found in anterior cingulate, in posterior cingulate, lateral prefrontal, medial prefrontal cortex, and thalamus. Another very interesting approach that is not medical, and I should tell you this specifically, it's suggested by Dr. Daniel Amen, and he mentioned that in his opinion, there are 7 subtypes of ADHD. He identified classic or combined type with symptoms of inattention and distractibility and impulsivity. This type of people, they have normal brain activity, or they can have normal brain activity at rest, but when they need to do some task, the brain activity decreased, and especially in prefrontal areas. Also, they have problem in basal ganglia and in cerebellum. And this type of ADHD usually have dopamine deficiency and respond well to stimulant medication. Another type, in his opinion, is inattentive. They have like short attention span and all symptoms that is similar to traditional inattentive subtype. They also have low activation in the prefrontal cortex, and we talk now about blood flow in frontal cortex. And this type of people also respond quite nicely to the stimulant medication. Then there are other type, like over-focused. They have mental flexibility problem. They can shift attention from one task to another. They sometimes can be stuck in some thoughts or some behavior. And usually these people have excessive activation in the anterior cingulate cortex that is involved in this mental flexibility control. This type of people, they usually respond well to some antidepressant medication. And it's found that they have dopamine and serotonin deficiency. Why I'm actually showing you this, because sometimes, at least in neurofeedback clinics, we have people who claim that they can't or they don't want to use some stimulant or traditional medication because it doesn't help them, or they have severe side effects, or they have a strange reactivity to this. And that's maybe the reason why, because we have different subtypes of ADHD with certain specificity in the brain functioning, and these people need different type of approach in medication also, not just neurofeedback. Anyway, these 7 subtypes also include temporal lobe subtype, which is presented with temporal lobe abnormalities and also decreased activity in prefrontal cortex. They could have some anger, aggression, behavioral control, learning, memory problems, and they can respond well to anticonvulsant medication. He also mentioned about limbic subtype with chronic low mood, but not depressed. People who has low energy, frequency, this type of clients, they usually say that they have some helplessness, low self-esteem, and sensory hypersensitivity. So excessive activity in the limbic part of the brain they showed, and also decreased prefrontal cortex activity in rest and in task both. Then there impulsive part, which is also can be unpredictable and speaking fast, and they have like hyperactive brain. And stimulants usually doesn't help them so much. There was somebody, sorry, there was somebody doing something, was some comments or anything on the screen, Alex? Sorry. Okay, anyway, and the last one is anxious. These people, they of course have anxiety or tension. They have some stress symptoms. They can also show some headache or stomach ache and so on. These people have usually high activity in basal ganglia, and stimulant also doesn't work for them. So quite interesting, scheme and way of thinking about subtypes of ADHD. Because actually other people also mentioned that we have different subtypes of EEG, like we call it, and I'm going to tell about this later, sorry. Okay. I was a little bit distracted, sorry, because there was something on the screen and I don't understand where it's come from.
Actually, we can restart the screen sharing because it looks like you can draw on your screen, then you with the mouse click, I guess so.
It's not me. That's the problem. That is not me.
Okay, that's interesting.
Okay.
So if you want, we can restart the screen sharing. You can just stop
okay,
it.
Let's try. I just try to continue. Okay.
Okay, no problem. That's fine.
All right. So again, about neurobiological basis, and this is very important. As I already mentioned, people with ADHD, they have problem in prefrontal cortex, cerebellum, anterior cingulate, basal ganglia, temporal lobes, and limbic system. What these areas are or systems they are doing. So prefrontal cortex and cerebellum involved in concentration, attention span, executive functions, organization and planning of motor activity, anterior cingulate mental flexibility, error detection, basal ganglia dopamine production, and also many other things, temporal lobe, memory, learning, and emotional reactions, visual processing, and limbic system, emotion regulation, and reactions to stress. What type of brain abnormalities generally found if we talk about EEG studies? In EEG, usually found increased theta frequency in the frontal area. And it means that there are some executive and attention control problems. And this type of people usually respond well to stimulants. There are also ADHD type that have increased alpha frequency in the frontal areas. They have affective symptoms, also executive and attention control, and they may respond well to some antidepressant. Then there's interesting beta type of ADHD. And this type of people, they are very moody and they have different type of behavior. So as you can imagine, there are different specific characteristics in EEG that we can identify. For example, we can calculate theta beta ratio. So this index telling us about how much, what's the level of activation in the frontal area. Also in ADHD, we can found some local abnormalities, increase of some specific frequency at certain areas, like in frontal area, we can have alpha, for example, or we can have local theta or even delta waves. We can also find some paroxysmal activity. So based on the research, it was found that ADHD, that we can identify ADHD phenotypes, EEG phenotypes, and we can name them like frontal slow variant, slow alpha peak variant, frontal alpha, alpha that is always persistent, even if we ask people to open their eyes. Normally it shouldn't be so much alpha in the cortex, but this type of people, they have alpha in both cases. Then there are frontal beta spindles, low voltage EEG, paroxysmal, and temporal alpha. So the same type, I already mentioned previously that DSM-5 telling us about that there are three main types of ADHD. But if we talk about EEG analysis or quantitative EEG analysis, that we have actually, that we can also identify even extra subgroups. Like in one study of Clark, it was found that combined ADHD type can have increased slow waves activity and decreased fast activity, but at the same time they can have high amplitude theta and decreased beta or even excessive beta. Another study found that ADHD impulsive type related to abnormalities in the temporal occipital areas, combined subtype related to abnormalities in different areas like frontal subcortical circuit or frontal limbic pathway, temporal occipital areas, and also abnormality in motor system. So all what I show you is just to explain that it's not an easy way to identify specific subtype of ADHD, and we need more information every time when we're dealing with real subject and with real client. Also, a lot of information exists now in the PubMed, and there are a ton of information about ADHD, because this disorder was extensively analyzed, and but same time many studies was done on a group. And when we talk about the grand average, of course we lose some information. We can find some specific information that is somehow help us to understand general problem for this disorder, but then we lose the information that we need when we deal with real subject. And we can use quantitative EEG analysis in addition to the clinical practice. For example, if you are a psychologist or you're a psychotherapist, you can learn to use EEG. It's really affordable. It's not so complicated. Just you need to understand how to apply the electrodes, and then you can apply this functional brain diagnostic for your practice to understand your clients better. Like, for example, normal EEG, how it looks like, or if you have some pathological sign in EEG, how it looks like, and what you can do with this. With MITSAR, you can have it really in different settings. We have a wired or wireless EEG. You can perform EEG analysis long-term, or you can do just short-term recordings, like with eyes open and eyes closed, what we usually use in quantitative EEG analysis. Also, you can do ERP registration, you can do normative database comparison. Everything is possible to help you to understand your patient better. In MITSAR software, you can do rapid remontaging and pre-processing of the data. Like usually, if you have client, especially with ADHD, and it's a small child, is going to have a lot of artifacts, but also adults. Many of them, they sit still. So we have automatic denoising, and we have special algorithm that help you to clean out unnecessary artifacts based on independent component analysis algorithm. Then you can do some group analysis if you're doing research, and you can also do grand average. But what is the most important, that you can analyze individual subject and perform some power frequency like to do some fast Fourier transformation, to create some brain maps, and to identify the source of the biggest deviation in the brain. Event-related potential is another story. So we have a bunch of tests that you can present to your clients and understand the stages in information processing in the brain. It's a little bit different approach, but still it is also processed EEG. So we can record EEG during task performance, and we can analyze what happened in the brain. Like, for example, children with and adults with ADHD often have problem in go and no-go component, and people with anxiety, they could have problems in some another type of components or processes in cognitive processes in the brain. This is the real cases, and I already told you about different type of EEG or EEG phenotype. what you can find in this heterogeneous population in real subject, not something from the publication of thousands or hundreds of kids. So for example, you can have this paroxysmal EEG phenotype when you have pathological high amplitude deviations, and this person never was diagnosed with any epilepsy, but already was diagnosed with ADHD. So understanding that he has some specific focus in his brain, helping to redirect this client to other specialists to exclude any pathological situation, or maybe to combine neurofeedback or whatever you are doing, psychotherapy with medical, with pharmacological help. You can also have a like frontal slow variant client. For example, this person suffer from inattention, emotion control, fatigue, and especially was telling me that fatigue is the biggest problem, was diagnosed with ADHD inattention type and emotional dysregulation. So the problem, what we found with this analysis of qEEG, it was decreased activation in the frontal areas, and especially in cingulate gyrus. And also the same person has problem in posterior parietal lobe. So probably attention switching was hard for him. So some part of attention regulation is not perfect in this client. So a specific type of neurofeedback therapy was suggested. Then there are also frontal slow variant. This person came with inattention and sleep problem, especially suffer from insomnia for very long, was diagnosed with ADHD and has increased theta-beta ratio, both increased alpha and increased theta, especially in eyes closed condition, was found in the frontal areas again. In VCPT task in ERP studies, we found that variability of reaction time increased, and it means that he can sustain attention for a long period of time. And his EEG in eyes open, you can see, was embedded with alpha rhythm, and the person is 21 years old, so it's quite abnormal. It looks quite abnormal for me, so it's high amplitude alpha. In ERP, deviation found in P1 and 1 component, it's visual processing component. So it means that his sensory channels is overactivated, and same time Go component was decreased. So he feel tiredness, and he's not impulsive, even more apathy he feeling. Another example of possible phenotype is mixed fast and slow phenotype. In this case, we can have both decreased activation, like this increased alpha in certain areas, and at the same time increased activation in the same areas. Sometimes we see this kind of pattern of EEG in people with under specific medication. This was unmedicated person, was diagnosed with ADHD, inattention type, and also emotional dysregulation, some problem with sleep. Actually has also some pathological activity in the brain, and theta-beta ratio was decreased, so it's even more like over focusing than traditional ADHD person with increased theta beta ratio who has a problem to activate frontal lobe. And the problem was in parietal areas, in Brodmann area 7 and Brodmann area 40. That quite explain some problem with sleep regulation, because people have who has insomnia, they often found to have problem in parietal areas. Performance in VCPT test was very good and no any problem related to information processing besides significantly increase monitoring processes in the brain. And we found problem in anterior cingulate or limbic lobe, which is also can explain ADHD symptoms, and problem with mental flexibility. So like some parameters of our analysis, they support each other. So that's why actually we are doing so extensive analysis that we have not just one parameter, not just one measurement, but many measurements that will answer or support a certain theory about particular client. Also, you can have the situation, then it's hard to distinguish if you have just clear type. Like this person has temporal alpha, but same time also frontal slow variant. So both problems we can identify. So here in temporal areas, it was theta and alpha activity, but also down-regulated frontal areas. And this person was diagnosed with ADHD combined type, has inattention, and was slow, like at least he described himself like slow, and feeling apathy, so not enough energy, but same time has increased go component, which is actually telling us that he has some impulsivity, and decreased no-go component. It means that it's hard for him to restrict unwanted behavior, to suppress unnecessary action. But test performance was within normal range, which is also sometimes controversially, right? We are expecting that performance in ADHD person should be bad or should be deviated at least at some point, but it's not always the case. So you could have abnormal information processing in the brain, some components of information processing, but at the same time performance is okay. So all of this presentation is just to tell you that if you have a real case and the person comes with ADHD and telling you that he has abnormal response to medication or maybe some severe side effect. So in this case, quantitative EEG analysis and ERP analysis can help you to understand your client better and maybe suggest some specific therapy. You also can create individual approach in neuromodulation or psychotherapy, whatever you are using in your everyday practice. And I hope this short presentation was informative. I didn't make you tired with a lot of information presented here. And if you have any question, please feel free to ask. Thank you very much for your attention.
Thank you, Olga. Thank you everyone for coming. Actually, you can type your questions in chat, or you can ask them later if you are not sure how to do it now, and we'll be happy to answer. And by the way, if you already have some kind of EEG equipment, you are using it in your practice, and you want to increase your
knowledge and go deep inside brain mapping and even related potentials, and to learn how to use these techniques in your practice, you're welcome to contact us, because we also offer face-to-face consulting and education. So I see that we have something in chat. Olga, can you please explain a little bit more about low voltage EEG, please?
Just a moment. Low voltage EEG is just one type of EEG when the amplitude of the EEG signal is really small, and it can be in the reason for this can be broad, but like starting from improper analysis, when you during the denoising procedure you just cut off quite a lot of information, or it can be a sign of neurodegeneration. This is also one possibility. So it's I don't know exactly what else like what exactly.
Maybe also the question was regarding the low voltage. Yes, it was low
voltage. Yeah,
that's fine. That's okay.
So
we have one more question if you finished, or you want to go ahead.
So like I just was going to say that the reason for low voltage recording can be like many reasons. Of course, we sometimes even see this type of EEG in ADHD cases, but quite often we see this type of pattern in adults or even elderly clients.
Okay, we also have Jared asking us a question. I would like to unmute him, but I'm not able to do that. So let me try again. So anyway, hello, Jared. Just want to say hello to you. Hope you are doing well during this COVID times. Can you? Yeah, you can ask your question in person. Please do that.
Hi, Olga.
Hello.
Hi there. You mentioned in the beginning that the inattention subtype has temporal occipital issues, and I was wondering if you could just explain how that kind of gives rise to inattention. Does it give rise to some kind of visual scanning problem?
It could be. It's depending of what the reason for temporal occipital issues. Usually we find some epileptic focus there, or some abnormal activity. Let's don't talk epileptic, but still. And of course, if you have this type of abnormal focus in the cortex, it means that you can have a bunch of different type of abnormalities, and visual processing, of course, will be complicated for these people, especially if it's temporal occipital. So they may have some learning disabilities, which is coexist often with ADHD. And also some researchers, they try to understand also this phenomenon, and they mentioned that sometimes it's also the reason for this temporal occipital abnormalities, what we see in quantitative EEG, can be not because of the physiological reason, but because of the recording style. So some re-referencing can help to understand better if it's really temporal occipital or something else. I don't know if I answered your question.
Yeah, Jared told us thank you. I think
thank you for a question. Yeah.
Anyone else who would like to ask the question? Okay, it seems to be that No more questions for today. Once again, I want to say that you will be able to access the recording of the webinar. We'll put it on the YouTube and also give you a link on Facebook in our event group. So hopefully you enjoyed it. And again, if you will get any questions in future, you can ask it either on Facebook or by email. So feel free to contact us. And stay tuned. We will do the next webinar very soon. Thank you everyone for coming. Have a good rest of the day, wherever you are.
Thank you, everyone. I hope it was informative. Thank you.
Yeah, it seems to be that we have a positive feedback.